Alrighty. For the sake of time, I am going to be starting the webinar now because we have a bunch of great content. First and foremost, thank you so much for being here. My name is Hugo Aguas. I'm a research associate here with the National Healthcare for the Homeless Council. Um, we also have Anna Ramos from the Community Health Center, and she is going to be presenting later on today. First and foremost, really, I would like to extend my warmest regards to all of you. I hope you, your staff, and family members are all staying safe as we go through this period. Um, and for training and educational purposes, this webinar will be recorded for future use. This webinar is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the US government. I would like to take the time to ask you to introduce yourselves in the chat. Please share your name, agency, and role. And while you folks are all doing that, here are some instructions about how you can engage during the chat today. We want to hear from you, and we welcome your questions and stories throughout the chat. The more you all engage, the better the chat will be. You can type directly into the chat pod on the bottom of your screen. Your comments will show up to all participants, and I'll refer to comments and questions at the end of the presentation. By the end of this presentation, you will be able to conclude 3 things. You will be able to summarize barriers to primary care amongst people experiencing homelessness. You will also be able to explain the link between food insecurity, BMI, and diabetes. You will also be able to develop an appropriate method to discuss with your patients about BMI, diabetes through a trauma-informed care lens. First, I want to acknowledge that homelessness is pervasive. It has destroyed lives, opportunities, and has unbridled financial implications. According to USC, nearly a third of individuals experiencing homelessness reside in California. In the last decade alone, there has been a 22% rise in homelessness. According to HUD, in 2019, about 567,000 individuals were experiencing homelessness on any given day. And in California, 72% of the people experiencing homelessness are unsheltered, which is the highest share of unsheltered homelessness of any state. All this really begs the question, what needs aren't being met while the housing crisis is concurrently occurring? Experiencing homelessness only worsens the type of health maladies many may already have. The experience also exposes individuals to other illnesses that they were not at risk of contracting if they were not unhoused. Take asthma, for example. Due to increased exposure to poor air quality, individuals who are outside do not have a place to shelter, which only exposes their lungs to toxins related to poor air quality. Due to COVID-19, many can no longer see their primary care provider get a break from the elements due to population restrictions in libraries, restaurants, and parks. Shelters were already in short supply, and due to social distancing restrictions, many may become even more isolated from services. An increase in social restrictions also equates to more dietary restrictions. On this chart to our left, you can see the number of people who have been diagnosed with health complications from the 2019 UDS dataset, which is gathered from health clinics in the country. The top 3 reported illnesses that were noted were diabetes, obesity, and hypertension. From the data, we learned that there were over 345,000 individuals who visited clinics with diabetes, and there were another 464,000 who were obese or overweight. According to one study, 57% of chronic homeless adults are overweight or obese. 52% of participants in the same study state they had meals from soup kitchens in the past month, and only 17% of soup kitchens have worked with a nutritionist or dietitian. And while extremely helpful, food kitchens leaves individuals without the option to choose, often having to eat pre-prepared meals. Soup kitchens in other localities who may supply food may also be at a disadvantage through the deprivation of a nutritionist or a dietitian. Engagement with food alternatives are critical in having conversations with individuals experiencing homelessness. A conversation about food choice is difficult due to the lack of options many may have. However, poor food options can influence the likelihood of being diagnosed with diabetes or being overweight, which leads to varying health complications that can ultimately lead to a premature death. Excuse me. Measuring BMI, body mass index, acts as a way to monitor your client's health. BMI is an estimate of body fat and a gauge of your risk for diseases that can occur with an increased intake of poor mineral-rich food content. The higher your BMI, the higher your risk for certain diseases such as heart disease, high blood pressure, type 2 diabetes, gallstones, breathing problems, and certain cancers. According to the American Diabetes Association, 7.5% of non-Hispanic white adults have diabetes. The rate is even higher for people of color. 12.5% of Hispanic adults have been diagnosed with diabetes. 11.7% of non-Hispanic African American adults have diabetes, and a shocking 14.7% of American Indians or Alaskan Natives have been diagnosed with diabetes. Minorities are overrepresented when it comes to being diagnosed as diabetic compared to non-Hispanic whites. All the while, diabetes was one of the top 10 related deaths in 2017. I really want to acknowledge that food options for individuals who are experiencing homelessness is not an easy solution by any means. However, addressing food insecurity is one way to lower mortality rates among people experiencing homelessness. It has been recorded that men who were experiencing homelessness were 2 to 8 times more likely to die from both chronic and acute illness than age-matched men in the general population. And many of those individuals may have support, such as SNAP or food stamps, but their food options remain limited. Because people experiencing homelessness lack storage, preparation tools to prep food such as rice, pasta, vegetables, and fruit, they are subjected to buy other foods that come high in fat, preservatives, and sodium. Food insecurity leads to an increase in BMI. Some have described this phenomenon as the hunger-obesity paradox. Food insecure items are often low in essential vitamins and minerals, but high in saturated fats and cholesterol, which leads to a more filling experience. Poverty-stricken individuals are thought to be skinny due to malnutrition and not getting enough food to eat. However, the opposite is true. Due to a lack of nutrient foods, individuals eat food that is often high in fat and sodium. Therefore, obesity is a consequence of overconsumption and poor food options. Obesity may result from an adaptive physiological response to episodic food insecurity, which can lead to binge eating habits when food is plentiful. Starvation increases holding on to fat. The body goes into protective mode, which creates fat instead of muscle. This was especially true in one study for older individuals, women, African Americans, and Hispanics. Poor food options can lead to high BMI, which in turn may lead to diabetes and other health maladies. At this portion of the presentation, we will discuss ways to support people experiencing homelessness. If possible, store patients' insulin at the clinic and dispense one vial at a time. Suggest storing insulin in an insulated bag. Provide insulated bags for insulin storage. If refrigeration is unavailable, insulin can be safely stored at temperatures between 36 and 86 degrees Fahrenheit for up to 1 month. Therefore, it is recommended that patients avoid carrying insulin inside pants or shirt pockets. Diabetics are prone to longer recovery times. If an appendage such as a foot is injured, the individual may sustain grave injury or loss of a limb. Therefore, it is imperative that you teach screening techniques on self-care. Smoking cessation is also an important component of education on diabetes complications. While difficult, practice harm reduction techniques by encouraging them to smoke less or substituting the craving with an activity. Finally, provide a list of healthier food options at a fast food restaurant. Acknowledge that healthy food choices are difficult to come by. Educate your patients on insulin and needle usage, and promote exercise when possible. On top of all of the healthcare needs one is going to face, patients will have faced days, sometimes years of trauma that vary in degree. Trauma is defined as exposure to an incident or series of events that are emotionally disturbing or life-threatening, with lasting adverse effects on the individual's functioning and mental, physical, social, emotional, and/or spiritual well-being. This trauma comes in various forms, such as criminalization, sexual and physical assault, lack of housing, food insecurity, untreated physical and mental health maladies, and employment discrimination. If we simply take criminalization, for example, by 2017, over half of all of 187 US cities had bans on loitering, camping, sitting, and lying in public. California cities average about 9 anti-homelessness laws. Los Angeles and San Francisco have 21 and 24, respectively. When it comes to things such as sexual assault as well, almost 1/4 of women state that their homelessness is a direct result of intimate partner violence. People who experience homelessness also engage in transactional sex for resources, which leaves them prone to violence. And for those who are food insecure, maintaining one's safety, obtaining food, and tending to other requirements to survive tend to eclipse the fundamental health maintenance. In 2010, 15% of the US population reported being food insecure. Hearth is skirted to the side to take care of more immediate needs in various instances. And finally, basic employment discrimination. Per the Yale Law Journal, interviews with homeless individuals and service providers revealed that finding stable employment is often the most common barrier to achieving or regaining housing stability. While homeless participants described a number of challenges to obtaining employment, they frequently referred to discrimination based on homeless status as one of their most pressing problems. Clients face a variety of challenges in their ability to access healthcare, which acts as a continuous daily stressor. The barriers and stressors come in forms such as scheduling appointments, not having a phone, lack of documentation, travel to certain locations, and competing priorities such as food and shelter. This is why it is important to build community partners, connect with their outreach worker, and if they don't have one, try to link them. Make a note about clients who are going through the housing process. Have a list of resources within the area to assist obtaining them an ID, Social Security, mental health services, food, and clothing. Most importantly, let them know that you're here to support them. And although one's past cannot be changed, we can read the script to identify causes, understand patients' experience, and intervene appropriately. One cannot change the trauma or even stop it from reoccurring. However, the approach to individuals who live in the street should come from one of understanding, one where practitioners can identify the causes and understand the trauma experienced by individuals who are experiencing homelessness. Now, unfortunately, many individuals who are experiencing homelessness must navigate a variety of systems to obtain care. However, we have the power to understand the world through their lens. If we do that, we have a chance at attacking the crisis of our time. As service providers, we must understand the trauma that our patients face on a day-to-day basis if we are to make progress. We can't change their trauma, but we can change their future by educating our population on healthier food choices, the empowerment of choice, and informing them of health risks related to diabetes and obesity. We understand that nutritional food scarcity is a daily occurrence. However, you can circumvent food scarcity by supporting and directing patients to food banks with low barriers. Help them enroll into programs such as SNAP or cash assistance programs to limit the burden one must undertake. Now for the second half, I'm going to be passing it over to Anna Ramos.
Thank you, Hugo. And let me just share my screen here. All right, so thank you for the opportunity to speak about this topic. It is something that I feel very passionate about. I work frequently with individuals who are food insecure. And I think that while it is sometimes a really difficult topic to speak about with patients, when we do take action to address our patients' food security status, it can have significant impacts, positive impacts um, on their overall health, both physical and mental health. So my hope is to be able to provide you with some ideas for providing care for your patients affected by food insecurity, particularly with those who are also affected by diabetes and obesity. So, sorry about that. So I want to start by providing a definition of trauma to expand on the one that Hugo provided. So trauma can be defined as physically or emotionally harmful or life-threatening events that can have lasting effects on an individual's health and well-being, including the individual's relationship with food and their risk of developing chronic diseases, including diabetes. So one form of trauma often seen for an individual's experiencing homelessness is food restriction. Food restriction is a form of trauma, and it can look different ways. So for some, it might be food restriction might look like just running out of food, not having enough food available. But it can also be not having access to the right kinds of food to nourish your body and to promote optimal health. Additionally, food restriction can also look like purposeful food restriction, as in when one is following a very restrictive diet for the purposes of weight loss, for example. So, so when providing care for um, our patients who are experiencing food restriction or food insecurity, we want to keep in mind what their food access and food restriction situation looks like. So the goals of trauma-informed nutrition care are not just to increase access to healthy food, but also to provide nutrition education in a way that recognizes how stress and adversity affect human health and behavior, in a way that avoids shaming, stigmatizing, and blaming our patients for their health conditions, and in a way that promotes resilience in our patients. So I want to provide some examples of food-related trauma or adverse food-related experiences. There are some examples listed here, and I'll go through them briefly. So we have unreliable and or unpredictable meals. Again, this can look like running out of food, but it can also look like maybe the patient who is relying on food pantries for a lot of their groceries and sometimes maybe receives food that they don't know how to prepare. Maybe they don't have the knowledge or the cooking skills to know what to do with that food. Maybe they get vegetables one week that they've never seen before. They have no idea what to do with it. And so this in a way can lead to unpredictable meals. I mentioned food restriction already. Similarly to that, excessive control over food can be another example. So think about your chronic yo-yo dieter patient who is either on a restrictive diet in an effort to lose weight or is off that diet and is gaining weight. And this kind of vicious cycle leads to this excessive control over food, and often that can then lead to an increased likelihood of overconsumption of the foods that had previously been restricted. Body shaming and weight bias are other examples. Body shaming can also can come in many different forms. I think the most obvious example is you think about the weight-based teasing or bullying that is experienced sometimes in schools from peers. Weight bias is also something that is very prevalent in our society. In fact, it's been documented in research to even exist in the healthcare setting. Loss of food traditions is another example. Manipulation, punishment, or rewarding with food. I see this most frequently in the parent-child relationship. So using food as a way to encourage or discourage certain behaviors. Shame, bias, or stigma when utilizing food assistance. So when utilizing food pantries or soup kitchens or SNAP benefits. and untrustworthy or inadequate nutritional supports. So I think we all know that there's a lot of misinformation out there about food and nutrition and health in general. So the reason why this is important to know about is because there are certain dietary behaviors that can result from these adverse events. So those are listed here as well. Some examples include hoarding food, binge eating, compulsive overeating. These are dietary behaviors that most commonly are seen from excessive control over food, food restriction, as I mentioned earlier, and also the punishment and rewarding with food can result in this type of behavior. High fat, high salt, or high sugar diets are also more likely to occur in those who have previously restricted those foods or have had some form of excessive control over those foods in the past. Reliance on convenience foods, decision-making to meet short-term rather than long-term needs, especially as it pertains to health goals, and deprioritization of planning and budgeting, particularly with regard to food preparation. So while we as providers, as healthcare providers, may not have control over these things that our patients experience, one thing we do have some control over is the weight bias in the healthcare setting. So I want to take a couple minutes to talk a little bit more about weight bias in the healthcare setting. Weight bias can be defined as negative stereotypes directed towards individuals affected by excess weight or obesity, often leading to prejudice and discrimination. So the most common stereotypes expressed by health providers, so this is expressed by doctors, nurses, psychologists, even dietitians, it's been self-reported in various studies that there are self-reported beliefs that patients affected by obesity are more non-compliant, dishonest, lazy, lacking in self-control, weak-willed, unintelligent, and unsuccessful. Furthermore, doctors tend to spend less time with these patients on preventative healthcare measures. And knowing that obesity is an incredibly complex disease, and that research suggests that long-term weight loss is often not sustainable. Therefore, these are the patients that need more care, more compassion, and more counseling. So I encourage you to consider if you hold any of these beliefs towards patients in larger bodies, and consider that it does not help our patients to hold these beliefs. In fact, it often contributes to worse health outcomes. So I want to explain that connection there. The impact of weight bias on patients is demonstrated nicely in this image here. We see that a patient who is affected by obesity starts to experience the health consequences associated with obesity, whether it be diabetes, hypertension, and then that often leads to increased medical visits to help manage the diabetes, the hypertension. In those increased medical visits, if the patient perceives weight bias in the healthcare setting, then this often leads to negative feelings resulting from that bias. Often it's feelings of inadequacy, of shame and guilt. And then those negative feelings often lead to an avoidance of healthcare, avoiding the place where they felt stigmatized. And then that avoidance of healthcare often leads to an increase in unhealthy behaviors and poor self-care, which then further contributes to obesity. So we have this vicious cycle that starts to occur. So what can we do to address weight bias in the healthcare setting? The Obesity Action Coalition and the Yukon Rudd Center for Food Policy and Obesity have some recommendations, and I've listed some of them here. So what we can do is, one thing we can do is ensure that your clinical space is weight inclusive. This might include an assessment of things like the furniture in the waiting room and the exam rooms. Do you have chairs available without arms so that your patients in larger bodies don't get stuck? Or do you have chairs with larger cushions so there's more space? Do you have medical equipment to accommodate larger bodies? Things like, are the exam tables wide enough? Are there gowns and blood pressure cuffs available for larger bodies? Are there scales that have higher maximums? And I want to note here that Just having that stuff available is not enough. We need to also make sure that the use of that medical equipment or furniture or whatever is a seamless provision of care. So what I mean by this is, imagine there's really nothing more stigmatizing than, as a patient, being in an office setting and having a provider say something like, "Oh, hold on one second, I have to run over to the other room to grab the larger cuff for you." So making sure that that medical equipment and all of that is not just available, but readily accessible. Also, we can ask patients for their permission to be weighed at each visit. This is being weighed is often a very uncomfortable situation for many patients. And so when we ask for the patient's permission to be weighed, we give a sense of control back to the patient in an uncomfortable situation. And in that way, show some sensitivity to the uncomfortable situation. We can also avoid judgmental, even well-intentioned commentary when weighing patients. So I want to give you a quick example. Imagine you have a patient coming in for an annual wellness check. You weigh them at 260 pounds. Last year at this time, they were 240 pounds. And so you say, "Oh, you've lost 20 pounds. That's great." While your intentions may be good, what you don't know about that patient situation is that their mother passed away 2 months ago. And ever since, they've been smoking more, sleeping less, and can only stomach one small meal a day ever since. And so consider what message that sends to the patient, that comment. Essentially, that weight loss is important regardless of how it's achieved, even if it sacrifices other physical and mental well-being. So along the same line, we can also emphasize goals of health and fitness behaviors rather than only the number on the scale. So emphasizing the changes that a patient has made in their diet, or even something as simple as drinking a little bit more water, emphasizing those goals rather than only the number on the scale. And then celebrating those positive health behavior changes made by patients when they are made. So now I'm going to talk a little bit more about some trauma-informed nutrition education strategies specific for weight management. So first and foremost, if you have access to a registered dietitian at your health center, refer to them. Registered dietitians are trained and experienced in providing weight management counseling in a way that is consistent with long-term health goals, and in a way that considers food security status and takes into account a patient's food preferences and availability of food. Now, if you don't have access to a registered dietitian, or if your patient is just not ready to see a registered dietitian, because sometimes there is a lot of hesitancy there with that initial appointment with a dietitian, then here are some other ideas. Setting realistic goals and expectations when working on weight management is incredibly important. And this includes recognizing when patients do not have the resources and/or readiness level to successfully engage in active weight loss. And fair warning, this might be a big proportion or a big portion of your patients. As Hugo mentioned earlier in the presentation, patients who are experiencing homelessness are also more likely to experience adverse events, have chronic stressors, and just not have those basic human needs met. And because we know that obesity or that weight loss is an incredibly, it's something that can be very difficult and requires a lot of education, a lot of counseling, a lot of mental energy. Because of that, we really want to recognize when a patient just does not have the capacity to engage in active weight loss at this time, given their current situation. But let's say you do have a patient who has the resources, is ready to engage in successful weight loss. It's helpful to identify what that is. What is a realistic goal? The Institute of Medicine defines successful weight loss as 5% or greater reduction in baseline weight at 1-year follow-up of initial treatment. So for perspective, for a 250-pound person, that would be a 12.5-pound weight loss over 1 year. Very different from some of the expectations that patients have when they come to us. So how many times do you have a patient that says, I want to lose 50 pounds in 2 months? And so guiding that patient to setting more realistic expectations is really important so that we don't set them up for failure. We can also use the guideline of a half a pound to 2 pounds per week rate of weight loss as another kind of good goal. But again, this guideline should be further tailored to the patient based on their food access and food preferences even. Another thing you can do is ensure that nourishment is prioritized over restriction. And what I mean by this is that getting adequate nutrition is more consistent with long-term health than is losing weight while being malnourished. So getting adequate nutrition includes being able to eat when you're hungry and stop when you're full, have access to all 5 food groups and a variety of food choices within those 5 food groups. And so we really want to, when we're providing weight management counseling, especially for patients who are experiencing homelessness or food insecurity, we really want to make sure that they are not making dietary changes that are going to further diminish their nutrition status. And lastly, assess for binge eating. As mentioned, food restriction, purposeful or non-purposeful, can be something that increases risk of binge eating behaviors and binge eating disorders later on. So assessing for binge eating behaviors is very helpful so that that patient can be referred to, if those behaviors are present, we would want to refer that patient to a mental health provider, ideally one specialized in eating disorders, as well as a registered dietitian, ideally one specialized in eating disorders, so that that binge eating behavior can be addressed before making weight loss goals. So now I want to talk a little bit about some trauma-informed nutrition education strategies more specific for diabetes management. So one thing you can do when providing diabetes counseling, nutrition counseling, is encourage consistent carbohydrate intake. This is particularly important, I think, right now, because there's a lot of fear and misconceptions about carbohydrates. And what we want to promote in our patients with diabetes is that you don't need to eliminate all carbohydrates. In fact, what you want to do is have a more consistent intake of carbohydrates, kind of spread evenly throughout the day, and focus on more nutrient-dense sources of carbohydrates, higher sources that are higher in fiber, higher in vitamins and minerals, things like whole grains, oatmeal, brown rice, whole wheat bread, starchy vegetables, sweet potatoes, things like that. And I would say this is particularly important because many times for our patients affected by food insecurity, carbohydrate foods are kind of the staple of the diet. They're the most easily accessible, and they're the things consumed most often. So we don't want to promote that the one category of food that a patient does have consistent access to is that we're trying to eliminate that. So similarly, avoiding promoting restrictive dieting practices. So avoiding recommendations to eliminate certain foods or food groups, especially if it's a staple of that patient's diet. We can also encourage 3 distinct meals per day. So I think a lot of patients affected by food insecurity often have like an inconsistent meal pattern. They eat one meal one day and then graze throughout the day the next day. And so having a goal of having 3 distinct meals, a breakfast, a lunch, and a dinner, can help to stabilize blood sugar levels. Now, it is entirely possible that this is just not a feasible goal for some patients, and they may not have the food access to do this. So in those circumstances, it might be helpful to offer ideas for ready-to-eat, non-perishable foods that can be that are often easily found at a food pantry. So this can be something that they can, if they know they're going to miss a meal, if they don't have this ability to prepare a full balanced meal, then at least having something that again is ready to eat, non-perishable, available to eat, so that they're not entirely skipping a meal. This is a good approach. So some examples might be peanut butter and whole grain crackers, whole wheat bread and canned tuna, nuts and dried fruit. So again, these items are often found at food pantries, are non-perishable, can be kept on hand relatively easily. And then for patients experiencing hypoglycemia, some food pantry items that are good to keep on hand are those 100% juice boxes that are, again, non-perishable. You don't have to refrigerate those. And those little mini raisin boxes. Both of these options are already portioned out as that's a good portion size for bringing up blood sugar when experiencing hypoglycemia. And again, don't need to be refrigerated. So I'd also like to provide some trauma-informed communication strategies. So when you're providing this counseling, here are some communication techniques that you can use to be sensitive to your patient's trauma situation, their food security status, etc. So the first thing we can do is use person-first language. So this means using phrases like my patient with diabetes instead of my diabetic patient, or the person affected by diabetes instead of the obese person. The difference here is subtle but significant. So it takes the emphasis and puts it on the person rather than the condition. And this is important because we want our patients to know that they are not defined by their condition. We recognize that they are a person who is experiencing these conditions. And I would encourage that these phrases be used not just with your patients, but also with colleagues and with coworkers as well. We can also utilize open-ended questions when counseling patients. So this is an open-ended question is one that cannot be answered by just a simple yes or no. So for example, tell me about your weight history, or tell me about your blood sugar, or what does your typical day of eating look like? These types of questions promote or encourage the patient to describe in their own words what their situation is like. And this, while a little bit more time consuming, it does provide you with a clearer picture of what that patient's food security status is, what their knowledge of nutrition is, and what their knowledge of their health status and their disease state is. And that is all very helpful information to be able to better individualize their care and connect them with the right resources in the community. There's also, one more thing I'll say is that there's also some data to support that the use of open-ended questions is more likely to lead to better patient-provider rapport, as well as increased patient adherence to recommendations. And then lastly, we can ask for permission. So asking for permission when weighing patients, as mentioned previously, but also asking for permission when discussing some of these topics. So for example, saying something like, is it okay if we talk a little bit more about your eating habits? Or is it okay if we talk a little bit more about your weight history? Again, these topics are often very sensitive topics, difficult to talk about in an honest and open way for many patients. So asking for that permission, again, it gives the patient a sense of control over their care, and it shows the patient that you are working together as a team, that you have a vested interest in providing care to them that they are ready and receptive to receive. And that can also improve provider-patient relationship and rapport as well. So lastly, I want to leave you guys with some other resources, tools, support systems, ideas for increasing access to these. If your health center has access to community health workers, this is a great way to support patients in the community. Sometimes community health workers can meet patients at a food pantry or meet them at a soup kitchen. And utilizing those resources for the first time can sometimes be very challenging. There's a mental hurdle that has to be overcome for some. So having someone there with you to do that for the first time can break down some of those barriers. So bringing them into the team as part of the treatment support Also, community gardens are another way to increase food access. So having some resources for your area, knowing where there are community gardens and what the process is for utilizing those gardens can be another great way to increase food access and also provide a kind of therapeutic way to be more involved with food. Additionally, having lists of local food pantries and soup kitchens on hand so that they're easily accessible. This can also help normalize a patient's food security status. And then I've listed the SNAP info line phone number here as well for you to have on hand for patients who either need help signing up for SNAP. Again, this is the Supplemental Nutrition Assistance Program, often termed food stamps. And often patients just have questions about their eligibility status. So this is a helpful number to have readily available. So I'm going to leave it at that. And before we go to questions, I'm going to actually turn it back over to Hugo to discuss some other resources before we do the Q&A.
Well, thank you both for this webinar. Thank you both for presenting. I think it's been wonderful information that was shared. And Hugo has listed here a couple of resources that we'd like to share with you. And this recording, and just for everybody to know, this recording and slides will be shared with you, I believe in a week. It should be up and available. So we're happy to do that. One resource that I did want to share with you is we do have a nutrition guide that we created, I believe it was last year, with a great working group of registered dietitians as well that have some great resources as well. So we'll make sure that that gets included in the package to you guys. Hugo, did you want to add any more to the resources before we go to Q&A? Hugo, you might be muted.
There we go. Can you guys hear me now?
Yep, sounds great.
Beautiful. Thank you so much. Sorry about that. Anna, could you go to the next slide, please? So on the next slide, what you actually are going to be seeing is information on our BMI Learning Collaborative that's going to be led by Dr. Darlene Jenkins, who's our Senior Director of Programs. She's going to be holding a learning collaborative to improve clinical measures on BMI amongst your clients. And I welcome you all to register. I am actually going to be putting the link in the chat right now. And with that, I think we should be open to questions if anybody has any.
Yes, so we invite you to, again, put your questions in the chat. We'd like to hear from you all. I do have a couple of questions maybe to just get us started, as those who are thinking about them can post. In addition to questions, also feel free to share any practices that you've found have worked in your location or your health center as well. We'd love to also kind of hear about that and get a chance to highlight and spotlight that work as well. So I guess on that, Anna, this question is a little bit for you. I was wondering, as I was listening, in terms of some other types of trauma-informed practices that health centers can do, and this has often been something I've thought about even when I go visit my healthcare provider, is does weight have to be taken at that first interaction? I'm wondering if they can, if a good practice would be maybe in the middle of the visit that weight is taken. So at least those first, few minutes that you're with a patient, that concentration is more on the person. And again, you're just not thinking about these numbers. I don't know if that's something that is a practice or.
Yeah, so I think you hit the nail on the head there, Elena. I think that if you're in the situation where your health center does have that as a policy where weight needs to be collected and documented in the chart, maybe there are certain parts of the chart that need to be filled out for QI reasons, then I think that's a great approach, is to not have it be the first thing that is done, especially at an initial visit where a patient is totally unfamiliar to you and there's not a lot of background information yet, because there might be some like trauma or some kind of like negative feelings that come up upon being weighed. And so getting to know the patient a little bit first, asking some key background questions to get some more information first, I think is a really great practice to kind of be the standard approach. I think it will vary a lot from health center to health center based on like the policies that are already in place, but I think that should be a shift that we kind of actively promote, because of that, those negative emotions that can often come up, and how it can kind of be triggering for certain patients.
Yeah, thank you for that. One of the, kind of along the same lines, I have a question from Bobby Watts too, is, are there visits where weight just doesn't need to be taken as an essential piece of the care for that visit? I don't know if you can speak towards that a little bit.
Yeah, so I think for sure there are examples of times where weight does not need to be taken. I think we've gotten into the practice of it's just an automatic vital sign. And often if that vital sign is not going to be used for that particular visit, I have lots of clients who, for example, are kind of like frequent flyers to the health center and maybe are being seen bi-weekly or monthly. And in those circumstances, I would encourage us to think about as providers, like, do we need this information for any kind of like clinical reason? And if the answer is no, then yeah, leave that out as from the visit. I think there are definitely situations in which it is required and necessary, if there's a patient who maybe is being monitored for malnutrition, or for maybe one who is congestive heart failure would be another example of a chronic disease where weight is a little bit more important to monitor very consistently. But I think that there definitely should be some clinical judgment involved in making that decision of if it's necessary or not.
Wonderful. Thank you guys so much. And I guess another question that I had too, and just kind of more from, the council being a national training and technical assistance, I know we have a lot of health centers that might not have registered dietitians on staff. What kind of suggestions or partnerships can they be thinking about in terms of getting that more detailed care? I don't know if that's something that you might be able to give some insight on.
Yeah. So I wish I had more like tangible resources for that. I think that there is right now, there's kind of a big push towards like nutrition being a more integral component of care as part of the healthcare system. So my hope is that registered dietitians will continue to be more easily accessible. But I suppose one thing I will mention is for those who maybe are trying to refer out to registered dietitians, like maybe there's not someone there at the health center. One thing to be wary of is that there is a difference between registered dietitians and nutritionists. Nutritionist is a term that is not as highly regulated, and there's often not, like, someone can call themselves a nutritionist but not have gone through the same rigorous education process and internship that registered dietitians do. So if you are referring out to get that nutrition support, one tip that I have is make sure that it's referring out to a registered dietitian who is credentialed, rather than someone who is only a nutritionist.
That's great. Thank you so much. I don't know, Hugo, if you had any questions or anything else you wanted to share?
I actually don't. It looks like we're doing very well on time, which I'm very happy to say. Actually, Bobby just gave us a question. Let's see. Many HCH programs work with shelters, which they don't operate, but have co-located clinics. Any suggestions on the role of health centers can play in helping the shelter provide more nutritious food?
Oh yeah, interesting. So programs that work with shelters, which they don't operate but have co-locate. Yeah. Bring the shelter, provide more nutritious food. So I think that's a great opportunity for just I'll give an example. Actually, at our health center, that we had kind of an initiative to have the registered dietitians and community health workers actually go out and visit the food pantries, visit those we call them wherever you are locations. So it's like those locations where we have providers in the community in an area to provide care specifically for those experiencing homelessness. And so there was this initiative to kind of get RDs and health workers out into those areas to be able to better like visualize what actually is being experienced by the patient. And I think that provides a lot of insight to those who are providing that nutrition counseling. Some health centers that I've heard of also have their own food pantries available. So that might be a nice option, having like a health center develop their own food pantry, especially in certain areas. I think sometimes there is a lack of food pantries available, especially if the patient population that you work with often lacks transportation. If that's like a common barrier, I think that further decreases access to food pantries and getting to soup kitchens. So, so that's another approach that I've heard some health centers take too.
Thank you.
And I will say too, as we were preparing for this webinar, oh, there's another question. Oh,
awesome.
Let's get to this question before my comment. Is there a way health centers, HRSA, public health in general could move away from the usage of BMI as an indicator of health? BMI has a pretty problematic history. That's very true. And the science behind it is shaky. It is so integrated in our reporting from a quality perspective, but it does not feel like a patient-centered measure. I definitely, Anna, chime in, but I think just from a training and technical assistance organization, we are struggling with that with HRSA as well, just kind of, being held to our health centers with the return visits for these types of quality measures, and being held against that is definitely a tough thing. And yeah, so I feel you on that, Courtney. Buys, thank you for that question. Anna, do you, I don't know if you have a comment on that at all, but.
Yeah, well, just thank you for asking it, Courtney, because this is something that I think about all the time too. And I don't have a great answer. But I think that you're totally right to bring up the fact that BMI has a problematic history, and there's a lot of weight management position papers and other research that also recognizes that it's not a great gold standard anyway, because there's certain other measures that can be taken that really are more reflective of body composition, things like waist circumference or other body measurements. And even that there's some controversy around, but I think that, yeah, I would love to kind of just continue to expand that conversation, that BMI is just not often not a reflective indicator of that's consistent with health.
I definitely want to thank you just for that acknowledgement, Anna, as well, and as well for that comment. While we were doing the presentation, we were conscious of it, but I'm very glad that it was brought to the forefront of conversation at the end. Thank you. I'm going to give folks 1 more minute to submit any questions they may have. Yeah, let me see.
And while we're doing that, I really would encourage you all to check out the Learning Collaborative on BMI. There was a lot of topics that I think in preparing for this that we just couldn't get to in really an hour. So we'll dig a little bit deeper, hopefully, in those sessions. So.
One last thing I'll add to address Courtney's question is I also thought about how At our health center, there is a little bit of a push to do more trainings with providers on weight bias and weight stigma and sensitivity towards that. So I think that might be a nice like kind of springboard to help change the, have there be like a paradigm shift. If there can be like agency-wide trainings, similar to the way that there's often agency-wide trainings on cultural competency and cultural awareness, having weight bias and awareness of weight stigma be another training that is provided or even mandated is a great way to kind of encourage that paradigm shift.
Thank you. Well, it looks like we haven't received any more questions for the day. I want to thank you all for coming to this presentation. And if you have any questions at all, please don't hesitate in reaching out to myself or to Anna. Thank you, Anna, for being here. If you guys, if there's anything else we can do, please don't hesitate in reaching out. Thank you very much. Stay safe and happy holidays.